Good morning, everybody. I'm Aditi Malhotra, and I'm one of the New Jersey Fellows. Please join me in talking about the management of the anterior accessory saphenous vein disease, otherwise known as the AAGSV, the AASV. I'll be using these interchangeably, but we'll go into the relevance of that in just one moment. So throughout this presentation, I've broken it up into three parts. The first component is why. What is the clinical significance? Why are we treating the AAGSV? Then we will talk about who, when, and where. So the appropriateness of treatment, who's appropriate, when is it appropriate? And lastly, we'll talk about what and how. So what are the management options out there, and how do you approach picking which one to use? So first, let's talk about the why, the clinical significance of the AASV or the AAGSV. A question I'd like to pose to you all is AASV just a tributary vein? I would like to draw your attention to this article by Dr. Marlon Schell, who had actually given this presentation just last year. And the title of the article is The Clinical Relevance of the AASV. In this study, they looked at 2,604 patients. Some were in the primary group and some were in the progressive group, meaning that they had had prior superficial venous interventions. And there were three conclusions that were drawn from this study that I'd like you to be aware of. The first was that there was a high frequency of AASV disease in patients with primary reflux disease as well as after prior intervention. So this is very important in that the AASV has clinical significance. The AASV disease has similar disease severity as the GSV and reflux associated with the GSV. So this is another very important conclusion as far as the clinical relevance of treating an AASV disease. And lastly, and unfortunately, AASV disease has an alarming incidence of superficial thrombophlebitis. You can see the p-values that are on this diagram here, and these are the three main conclusions I'd like you to take from this article. So this article concluded that the AASV is more than just the tributary vein. It should be recognized as a common pattern of primary reflux disease eligible for intervention. This has been further reinforced by future studies and prior studies. Overall, the isolated AASV reflux is reported as high as 9.7%, although it can go up to 10.9% depending on what studies you look at. And it is the most common cause of saphenous vein recurrence after a GSV ablation, which is also very important to note. Next, I draw your attention to, again, a study by Dr. Marlon Schell et al. The refluxing AASV demonstrates similar clinical severity when compared to the refluxing great saphenous vein, which is what we had mentioned before, but this reinforces it. They looked at 241 subjects over 6 months. They looked at a AASV disease, GSV disease, and then a control group. And then they compared the outcomes of mean VCSS, presence of C2 disease, and presence of C3 disease. So the conclusion from this article was that patterns of reflux from SFJ to either the AASV or GSV poses similar disease severity and commonly suffer complications of venous stasis. So again, the clinical relevance of AASV is very, very large. Next, I'd like to draw your attention to a paper by our very own CVR and Dr. Lockenpel, Dr. Deal, and Dr. Pappas. So here you can see that the title is called Severity of Disease and Treatment Outcomes of the AAGSV compared to the GSV. In this study, which I will talk about the results a little bit later when it comes to management, but in this study, I just want you to note that it was seen that there was no difference between the AASV and the GSV disease severity and impairment of life. This was based off of RVCSS scores as well as the CIVI-Q20. Next, I'm moving on to who, when, and where. So who's appropriate for treatment? When is it appropriate to treat? At the moment, we have something known as an appropriate use criteria. So not necessarily a guideline, but something that came out in 2020. And many of the societies that are well known in the venous literature have come together to, inform us of what is appropriate and when it is appropriate to treat a patient with AASV disease. So here on this table, you can see that the left side has asymptomatic disease, the right side has symptomatic disease. And then if you look at this column here, 10, 11, and 12, it's talking about whether the AASV has reflux, whether it doesn't have reflux, but there is GSV reflux versus there's no reflux noted at all. And as you can see, the only time it was deemed appropriate to treat the AASV was when the patient is symptomatic, has C2 or C4 to C6 disease, and has AASV axial reflux leading to the affected area. Other than that, when it's C3 disease and symptomatic, for example, it may be appropriate to treat those patients. And then outside of that, meaning asymptomatic or there is no AASV reflux, in those cases, it is rarely appropriate or never appropriate. And again, we have another summary table drawn from the same paper. And as you can see here, it summarizes ablation of the AASV in a symptomatic patient with varicose vein, skin, or subcutaneous changes, healed or active ulcers, i.e. class CEAP 2, 4 to 6. When the AASV demonstrates reflux that is directed to the affected area, then it is appropriate to treat these patients. It may be appropriate if they're class C3, and the only reason for this is the edema can have a wide range of coexisting non-venous causes of edema. And then lastly, it's rarely appropriate when there is no reflux present. This paper had also commented on the evidence behind AASV ablation up until 2020, and it was deemed that AASV ablation is safe, it improves patient severity scores, and it has low recurrence rates at 1 year, all of which are very important things when it comes to our clinical decisions of when to treat our patients. Now I'll be moving on to the what and the how. So what are our management options and how do we decide which ones to use when it comes to our patients with symptomatic AASV disease? So here I've broken down and created a table so that you can see that there are thermal options and non-thermal options. In the thermal options, we have radiofrequency ablation, and then we have endovenous laser ablation. In the non-thermal options at the very bottom is our classical surgical stripping. And then as you're moving upward, you have the phlebectomies, the foam sclerotherapy, Varithena, MOCA, and cyanoacrylate. And I'll go through each of these and the evidence behind each one. In 2017, Dr. Gibson et al. Had come up with these guidelines regarding the treatment of refluxing accessory vein disease. So I will just discuss this and then we will go into each treatment separately. So it was deemed that the AASV reflux from the SFJ is common and it is common in primary venous reflux disease. The accessory venous reflux is a common source of varicose vein recurrence even after prior intervention, as we had discussed in the papers earlier in this presentation. Accessory vein reflux causes morbidity and possesses the similar disease severity as GSV disease. So this is very important. There's clinical significance to us treating these patients. Symptomatic incompetence of the accessory great saphenous vein, whether it be the anterior or posterior, should be treated with endovenous thermal ablation or ultrasound-guided foam sclerotherapy to eliminate symptomatology. This was a grade 1C recommendation that had been given at the end of the paper. Accessory venous reflux treatment using endovenous thermal ablation or USG foam sclerotherapy is as safe and effective as when you use it for a GSV and SSV treatment. And lastly, vein closure rates and symptoms/quality of life improvement from accessory vein treatment is similar to the GSV as well as SSV treatment results. So, as all of this is mentioning, the AASV is very important to not only recognize, but also treat, because our patients are significantly impacted by this, whether it be their quality of life or the severity of venous disease. Now let's go to classical surgical stripping. There was a paper in 2001, Surgery of the Lateral Accessory Saphenous Vein by Dr. Prinz et al. It was a case series with 30 patients who underwent surgical removal of the AASV and the first segment of the GSV. Under general anesthesia, they did high ligation at the SFJ, division and ligation of the GSV, and then stripping of the ASV combined with extensive thrombectomies of all the tributaries. And 3 years post-op, it was seen that 64% of patients had no recurrence, 25% had perforator reflux, and then 9% had complete GSV reflux. This paper by Dr. Messonnier, it was speaking all about the treatment modalities of the anterior accessory saphenous vein, but what was noted was that her own data was within this paper, and it mentioned that the clinical results for her were excellent after 1 year follow-up in 62 of 63 limbs. She only had 5% had grade 2 neovascularization at the SFJ, 6% had occlusion or absence of the proximal half of the GSV, and asymptomatic GSV reflux from the femoral vein perforator incompetence was also seen in 6%. Otherwise, her patient satisfaction was very high in her selected patients and selected group of patients. Next, we're going to move on to what we often use in our offices, which is talking about the radiofrequency ablation, endovenous laser ablation, phlebectomy, and ultrasound-guided foam sclerotherapy. This paper by Dr. Thevakumar and group discusses 33 patients who had undergone laser treatment of the AASV. 6 weeks post-op, 61% of these patients needed additional treatment with foam sclerotherapy. So I'll be touching base a little bit later about the importance of this note, but I would like you to note that a significant amount of them needed this foam sclerotherapy thereafter. 1 year post-op, 64.6% of patients had improvement in their Aberdeen varicose vein severity score. So again, very significant. Laser is very important to use when it comes to treatment of AASV, as deemed by this study here. The same group actually went on to do a second study to look at the basically the use of the laser in recurrent varicose veins. It was 11 AASVs that were treated at the time. 54% of them needed delayed foam sclerotherapy. Again, something I'd like you to keep note because we'll be talking about this in a little bit. And then patients did have significant improvement in 3-month post-op of, again, the Aberdeen varicose vein severity score. I would like to draw your attention to Dr. King et al.'s study that was completed in 2009, and they essentially took a look at 56 limbs with AASV disease. They treated them with different frequencies of laser ablation, and they also did concomitant ultrasound-guided foam sclerotherapy. At 1 year post-op, it was sustained and statistically significant response and improvement in the vein disability score, as well as the Aberdeen varicose vein score. So again, treatment with laser, treatment with foam sclerotherapy was very effective, not only in the severity of these patients, but also the quality of life. And the severity of patients. Next, in 2010, we have Dr. Bradbury et al., and they took a look at ultrasound-guided foam sclerotherapy. They took 139 limbs and they treated it for AASV incompetence. 93 had been primary and 46 had been recurrent disease. And when they took a look at these patients 2 years post-op, it was seen that only 3.6% had recurrent reflux. So again, very effective. And these two studies done by some of our very own, I would like to draw attention to. Essentially, Dr. Sufyan et al. For both of these studies had concluded that the incidence of EHIT is not greater after EVLA or RFA of the AASV versus the GSV. So it doesn't matter which of these thermoablation, modalities you use, the E-hit was not greater when compared to the GSV. Next, we have the study by Dr. Cavallini et al. They were looked at 9 incompetent AASV veins. And again, where we're looking at laser therapy of these patients. Most of them returned to daily activities after 3.8 days. No patients had developed paresthesias or phlebitis. 5 patients had mild pain, and the VCSS, however, had improved from 3.2 to 0 at 17 months. So again, a very significant improvement that's seen in the severity here. So this study had concluded that endovenous laser ablation of the incompetent AASV with a laser is safe, it is efficient, and it is a therapy option with a very high success rate and no evidence of GSV, neoreflux, or recurrent varicosities during the follow-up period. And now we come back to a patient, a study done by CVR, and I had kept mentioning to you all the importance of addressing those tributary veins. Throughout many of the other studies had mentioned that those tributary veins were important to address. So here we have the severity of disease and treatment outcomes of the AA-GSV compared with the GSV. And as you can see, this was a significant amount of patients, 31,000 patients, approximately 49,000 limbs. It was broken down into isolated AASV reflux versus isolated GSV reflux. And then 2 different kind of treatment modalities had been looked at. One was ablation, and then the second was ablation plus phlebectomy. And in these patients, as you can see by these charts, I've summarized the 2 conclusion points I'd like you to take home with you. Both interventions, whether it was standalone ablation or ablation plus phlebectomy, had improved the AASV disease. However, to achieve the same degree and maintain the same degree of post-intervention quality of life improvement that was seen in GSV disease, when it comes to AASV disease, it is very important to address those associated tributaries with phlebectomy. So you want to do both an ablation plus the phlebectomy of those associated tributaries to maintain that same degree of improvement when it comes to quality of life. Even though severity had improved, no matter what, the quality of life to maintain that would be important to address these tributaries. And this is a systemic review, essentially taking a look at, it ended up being 15 studies, although initially they had started out with looking at over 800 studies. And what they wanted us to draw from their conclusions were that the pooled anatomic success rate of thermal modalities, meaning RFA and EVLA, were 91.8% with moderate heterogeneity. Whereas when it came to cyanoacrylate, the pooled anatomic success rate was 93.6% with no heterogeneity. There were non-pooled anatomic success rate for phlebectomies was 97.9%. And then for ultrasound guided foam sclerotherapy, the pooled anatomic success rate was 79.8% with substantial heterogeneity. Unfortunately, when it comes to MoCA, there just is not a lot of evidence out there specifically for AASV. It is present for the GSV, but I was not able to find many studies that commented on MoCA when it came specifically to the AASV. So that is my presentation. I'd love to open up the floor to any questions.
Great presentation. This is Zoe. So I just wanted to make a comment on our paper that we did. We looked at phlebectomy, but in our extended, well, what we're planning for our extended papers to also add ultrasound guided foam and varithena to address the tribs. And you'll notice a lot of the other papers did use foam for the tribs. So it's just a different technique. And, you know, I feel, and I don't know, Peter, I know you use the phlebectomy a lot. You use more foam. But I think in the larger tribs in the thigh, it's harder to get good compression in the thigh after the procedure to address the tribs. So that may be why we see better results there with the phlebectomy, but we still haven't really looked at that. So that is a plan for one of our extended studies.
Yeah, so I have several questions and comments to make. So in regards to our study, out of all the papers you showed, Aditi, we're the only ones that separated out patients who had isolated AAGSV. All
Yeah.
of the papers that you mentioned were combined disease.
Yeah.
So the question that we raised with our paper is whether or not there's any value to ablating that proximal portion of the AAGSV that's straight. Normally, it's between 5 and 10 centimeters in length. And what we found was that when you just did the ablation alone, you didn't get the same degree of improvement. So the real question is the thermal ablation necessary for the AAGSV? Since most of it is tributary disease, and if you either foam it or remove it with a phleb, is that proximal stump really clinically relevant? Now, the concern is if you don't treat it, then you're going to get recurrences.
Right.
And to date, as far as I know, no one's actually done that study where they just did the tribs, left the stump alone, and then followed those patients to see if there's a higher recurrence rate. So the
Peter,
second thing is,
that may be insurance too, requiring you to do an axial before you do tribs.
I don't think so, Zoe.
No.
I don't think so at all. Most of the insurances won't let you do the AAGSV until the GSV has been treated. But I don't think there's any requirement that you do an ablation, alone in those patients. The
Not
other thing is
ablation
there's one
alone.
study that you didn't present, Aditi, and that's a prospective study by Dr. Thomas Probstel. What he did was he looked at patients who had AAGSV disease and then said how many of them were symptomatic and how many of them were asymptomatic. And then he followed them for 4 years. And what he found was that those patients, I believe it was 98 patients, had a significant increase in development of symptomatic disease over time if they weren't treated. And that's the only prospective study in AAGSV disease. And it was done for 4 years, and he had something like a 95 or 96% follow-up rate on those patients because it was a small study. So I would recommend that if you haven't read that paper, to go find it and read it because it's a really good study.
Yeah,
Finally,
I actually, oh, sorry. Yes,
ahead.
Dr. Pappas, I had read that when I was doing my literature search. I unfortunately did not include it in the presentation, but I had read it, yes.
Yeah, I think that's an important paper because it's the only prospective study that I'm aware of. And then, Dr. Schul's papers are mentioned a lot. Now, I have to say, I find those papers difficult to read because everything is a mixed bag of patients. So I'm not really quite sure what to make of that mixed group. When you're treating GSV and AAGSV disease together, I'm not sure which is the main therapy that's associated with improved outcomes. So that was, especially the one that was done from the pro registry, that to me is a tough read because he has something like 600 patients in it, but almost every one of them had combined GSV and AAGSV disease. And then finally, this appropriateness paper, I have to say I hate this paper with a passion because the methodology that they utilized in the appropriateness paper was essentially the opinions of experts. So they sent out a survey and they asked a group of people, to rank whether it's appropriate, not appropriate, all the categories here. And then they basically said, well, 9 out of 10 dentists recommend, blah, blah, blah. I mean, this is just absolute nonsense in terms of methodology used. But the reason why they did this was because they felt that there was a lot of fraud that was being committed out there, and there needed to be something in the literature that people can point to. So that when there's fights with the insurance companies, you can at least point to this paper. I understand why they did it. I'm just not a fan of the methodology that they utilized. So there's still a lot of questions on AAGSV disease. And finally, the last comment I'm going to make, if you look at the 5 or 6 studies that you showed, the majority of them have 30 patients, 40 patients.
I know.
They're all, I mean, even our study, which we had 100 isolated AAGSVs, is probably one of the largest studies.
It was.
But the problem is we subdivided those patients and we're into the 30s and 60s like everybody else is.
Yeah, this was the breakdown here.
Right, but the 91 patients with 103 limbs is probably one of the largest studies.
Yeah, it was. It was.
At least we made an effort though to try to separate out the 2 segments to see which, our argument is that people with symptomatic AAGSV disease are just as symptomatic as GSV disease, because the problem that we're having is insurance companies won't let us do AAGSV disease unless the GSV is treated first. And that's not based on any data that I know. I think it's just an impediment that they put there to try to limit access to care.
Right.
So
If anything,
what's that?
If anything, all the evidence points otherwise. So it would be nice for them to be able to update that into it.
Yeah. And, this whole argument about foam versus phlebectomy, it doesn't matter what you use to treat the only thing with foam, and everybody knows this and they accept this, is that the failure and recurrence rate is higher with foam. But if you need a second treatment, who cares? It's so cheap compared to phlebectomy or laser. Like in Europe, they prefer foam because foam is like pennies over there because of their healthcare system. So, that's why you see all this literature out of Europe about foam, because it's cheap. They could care less if they have to do it a second time. Who cares? A second injection, no big deal.
So Peter, I agree that we are the only one that separated it out. That's why I wanted to do this study, was to isolate it. But if you have isolated AAGSV disease and you're getting those on a treatment plan, if you have Anthem, you have to ablate the AAGSV first and then come back.
I'm aware of that, but that's why I thought our study was important, because we're trying to prove that that's a stupid policy.
Yeah, well, I get. I don't necessarily agree. I think that it is important to ablate the AAGSV, but again, we're both thinking anecdotally because there is no study where you separate them out and ablate just the tribs or phlebectomize the tribs and then get to the stump. But I don't know that that's going to be possible. But I think the biggest thing for me from the takeaway from our study was the difference in the type of disease between GSV and AA. AA disease is very much trib related, morbidity, pain, and thromboses, whereas GSV is more C4 skin changes. So, I think that's a big difference.
Well, I mean, the only thing I'll say before Shakib says anything is that study by Probstol, it shows that if you have combined disease and you leave the AAGs behind, the majority of those patients go on to progress. So I think there is enough data to show that if you have GSV and AAGSV together, that you should treat both. But right now, we all know that the insurance companies make us stage those patients. So, yeah, Shakib?
Yes, sir. First of all, Aditi, well done. Good presentation and very good review. I have just something in my mind that I have always bothered me, and I wanted to know if you come across in your review any major study or any study on posterior accessory great saphenous vein?
No.
Whether it is by itself or whether it is a comparison, because when I looked at in many years ago, and including even Zoe's excellent large study that we have been discussing, I don't see posterior accessory veins addressed. And I tried to collect in CVR many years ago, even while looking at ultrasounds, and I found only a few that I could really record, and then I gave up when even trying to document those. Have you come across with anything? If not, Peter and Zoe, can you help?
I haven't, but I can tell you, Shakib, that when I speak to Jose Almeida, he believes that if you do a GSV ablation and you have a reflux in posterior accessory vein, that there's a higher recurrence rate of recanalization because of that posterior vein. But that's all anecdotal in opinion. There are no papers and no studies that I'm aware of that look specifically at posterior GSVs.
And me neither, I agree, Peter. But I also, this is anecdotal, but see that it is more common in women that tend to have pelvic symptoms too, to have a refluxing PAGSV.
It's interesting because when we were doing in situ saphenous bypass surgeries, Peter, as you and I probably will be knowing, when you look at it directly, it seems many times the posterior is really a very significant vein, and we actually use it until we open the arterial side open. And the posterior is not as small or as insignificant compared to the anterior. And I always wondered, there is no study, we don't see anything, and I don't know why it is.
Yeah, I don't know either, but Zoe just said something that reminded me of another paper. I think it was from Malaysia, in which they looked at 2,200 patients, and they looked at the origins of some of these varicosities. And what was caught my eye in that paper is that 10% of AAGSBs do not have their origin at the saphenofemoral junction. They're actually coming from the pelvis.
Mhm.
I'm
So I think
glad
that's
because
another
I'm
important
glad
thing
you
to keep in
mentioned that,
mind.
Peter, because truly, when you look at it anatomically, because those of us who have done open surgery for a long time, you see that the junction and the various tributaries or veins that are joining at the saphenofemoral junction, the closer they are at the saphenous femoral, because anterior is very close. Sometimes it even comes from the femoral. But to me, I thought posterior is not that much important seen, is because it is further away and it is by itself, and it doesn't have any time where it is the valves may be defective and so on. And that's a very good point you reminded.
I'm gonna give a shout out to our upcoming study just getting accepted for the AVF. And I feel like this is what we're talking about here with the difference between above knee disease and below knee disease. So Neil Gadhook will be presenting that at the AVF in February, if anybody's interested in our reflux pattern study.
All right, anybody else have any questions? Well, another excellent presentation from our fellows. This year's been very high quality presentation. So thank you, Aditi, much appreciated. Everybody have a great weekend. And, look out for the email from Stephanie if you want CMEs for this presentation. Remember, you have to fill out the surveys if you want to get your CMEs at the end of the year. All right, guys, thank you very much.
Thank you, everybody.